Okay, next we'll have Dr. Corbett presenting Aspiration Thrombectomy of Bilateral DVT and the Management of IVC Atresia, a case report. Dr. Corbett's coming from Michigan Vascular Center in Flint.
All right. Thank you for the opportunity to talk today. I have nothing to disclose. IVC atresia is a rare congenital venous anomaly which is associated with an increased risk of developing high-burden lower extremity DVT at a young age and is an important etiology to consider in a young patient with an unprovoked DVT. The optimal treatments and management of IVC atresia are variable and understudied. We discuss our management option for occluded bilateral lower extremity DVT with known IVC atresia amenable to endovascular surgery. This is a 24-year-old female with a known history of IVC atresia and congenital absence of her left kidney. She was on birth control and is a non-smoker. She presented with bilateral lower extremity swelling, discomfort, and cyanosis, but no phlegmasia. Duplex ultrasound demonstrated acute bilateral DVT extending from the iliac veins to the popliteal veins. She was admitted to the hospital and started immediately on a heparin drip. A CT venogram obtained showed bilateral iliac DVT and absence of her IVC from the level of the iliac vein confluence up to the splenic vein. The arrows in the pictures here elicit dilated bilateral iliac veins due to thrombus, as well as dilated lumbar veins. There were multiple collaterals noted in the paraspinal region, shown in the top picture, which fills into a patent but engorged zygous and hemizygous veins. These subsequently drained into the superior vena cava. The following morning, the patient was taken for an aspiration thrombectomy. The patient was placed in the prone position. We accessed the bilateral popliteal veins. On the initial venogram, extensive thrombus burden was noted. The outflow of the venous system to the IVC was not visualized, and 035 IVUS system confirmed extensive thrombus in the iliofemoral system. So an Inari flowtriever was used to perform aspiration thrombectomy. Multiple aspirations were performed until very little thrombus was retrieved. As previously stated on the initial venogram, the outflow of the venous system was not clear. However, after the thrombectomy and clearing of the majority of the thrombus burden, the major outflow was noted to be a large zygous vein off of the right iliac vein traveling superiorly, and burst flow was now noted throughout the bilateral venous system. So postoperatively, the patient was resumed and continued for 24 hours until she was transitioned to Eliquis. She was discharged on post-op day number 2, and at 3 weeks, her bilateral lower extremity swelling was almost completely resolved. And so in summary, aspiration thrombectomy is a viable treatment option for acute iliofemoral DVT with IVC atresia.
Great. As people come up, thanks for that presentation, excellent. I had almost the exact same case a few months ago, and we used the Inari thrombectomy device, and we were happy with gigantic collaterals. And the patient rethrombosed a few days later, and I wonder if I should have used thrombolytic therapy to clean out more collaterals to their baseline. Was that considered, and are you thinking about reconstructing the IVC in a staged manner?
So that's a great question. There are some other studies that show that they only do thrombolytic therapy, and in our case, of course, we did aspiration and thrombectomy. It's kind of variable in the literature and kind of very understudied. I think either is a very viable option, but as far as IVC reconstruction goes, I think that is another good point to kind of have them to a referral service to be able to do that, because based off of their precipitating factors and why it reoccurred and what the underlying baseline is, these patients also happen to have a tendon thrombophilia as well, that they may need lifelong anticoagulation and actually may need their IVC reconstructed.
Yeah, that's what I was going to add. Ross Milner from Chicago. I'm actually only standing up here for one reason, because Dr. Muck thinks I only know where the aorta is and there's no other blood vessel in the body. So Patrick, I do know where the vena cava is. I just want you to know that. But this is, to you guys, both your points, and I obviously don't do a ton of this stuff, but I do think in younger people that have had this type of thrombosis, that anticoagulation long-term alone is never going to be adequate. And if they're an appropriate candidate for a surgical reconstruction, not a bunch of stents from the caval bifurcation into the atrium, but a surgical reconstruction is probably the right thing to do for someone who's younger and can tolerate that operation.
I definitely agree with that. And there was also a lot of mention about not placing stents unless you are reconstructing, because of course then you have no outflow.
Thank you very much. Thank you.